everyone. On today's podcast, we're going to talk about the evidence on inducing labor for going past your due date. Hi, everyone. On today's podcast, we're going to talk about the evidence on inducing versus waiting for labor when you're going past your due date. And I'm going to be joined by Anna Bertone, MPH, our research editor at Evidence-Based Birth, to talk about this topic. Before we get started, I have a quick announcement, and that is next week we are hosting free webinars for the public all about the evidence-based birth childbirth class. On Monday, March 2, we'll host a special webinar just for parents. We'll give you a peek behind the scenes at what it's like to take our evidence-based birth childbirth class. And then on Tuesday, March 3, we'll have a special webinar just for birth professionals to give you a tour of the evidence-based birth childbirth class so that you can decide if it's something you'd like to recommend to your clients or not. You can register for these free webinars at evidencebasedbirth.com/childbirthclasswebinar. That's all one word, /childbirthclasswebinar. All right, now back to the topic at hand, inducing labor for going past your due dates. Now, before we begin, I do want to give a brief trigger warning. In our discussion about the research evidence on this topic, we will be talking about stillbirth and newborn death. So there has been a ton of new research on the evidence on induction versus waiting for labor when you go past your due date. So much research, in fact, that we've decided to separate our signature article on due dates into two separate articles. So we still have the original article, The Evidence on Due Dates, which you can find at ebbirth.com/due dates. And although we updated that article a little bit, it's remained very similar to previous editions. It talks about the length of a normal pregnancy, factors that can make you more or less likely to have a long pregnancy, etc. But then we separated out the research on induction into a new article that you can find at ebbirth.com/inducing due dates. This is a peer-reviewed article that covers all of the research on induction versus something called expectant management for going past your due date. And in today's podcast, we're going to update you on the latest info that we found for that article. Just a heads up, we will not be covering the research evidence on inducing at 39 weeks. We already covered the ARRIVE study, a randomized trial that looked at induction versus expectant management for 39 weeks of pregnancy, in episode 10 of the Evidence-Based Birth podcast. And just a tip, if you're having trouble finding any of our earlier episodes of this podcast, iTunes has stopped showing the earliest podcasts, but they're still out there and you can find them on Spotify and any other podcasting app. You can also find info about the ARRIVE study at ebbirth.com/ARRIVE. So we're not going to talk about induction at 39 weeks. Instead, we're going to be focusing on the evidence on induction versus waiting for labor once you reach 41 weeks. And to do so, we're going to talk with our research editor, Anna. So welcome, Anna, to the Evidence-Based Birth podcast.
Thank you. I'm glad to be on the podcast again.
So I want to start by explaining to our audience a little bit kind of about the background of why this topic is important. Inductions for non-medical reasons have been on the rise in the United States and all around the world for the past 30 years. And increasingly more people who are pregnant are being induced for reaching their estimated due date. So we really want to cover the benefits and risks of elective induction for going past your estimated due date. And we'll also talk about whether or not your goals and preferences for your birth matter, which of course they do, but that kind of plays a role as well. So how often are people induced for going past their due date? Well, we don't know for sure because this hasn't been measured recently, but according to the 2013 Listening to Mothers 3 survey, which was now published about 7 years ago, more than 4 out of 10 mothers in the U.S. said that their care provider tried to induce labor. Inducing labor for going past your due date was one of the most common reasons for an induction. Out of everyone who had an induction in this study, 44% said they were induced because their baby was full term and it was close to the due date. And another 18% said that they were induced because the healthcare provider was concerned that the mother was overdue. The Centers for Disease Control in the U.S. also reported in 2018 that about 27% of people had their labor induced, but we think that that number is probably low and that the percentage of people who have labor induced is underreported in the Vital Statistics program in the United States. So Anna, can you talk a little bit about why there's so much controversy over this concept of electively inducing labor once you go past your due date.
So why is there so much controversy about elective induction? Elective inductions, by definition, are labor inductions that do not have a clear medical reason for taking place. They occur for social reasons, like the provider wanting the mother to give birth before the provider goes out of town, or for other non-medical reasons, like the pregnancy getting uncomfortable and for the mother's convenience. But there's also a gray zone about what constitutes an elective induction. Many providers only consider an induction to be quote unquote elective when the mother is healthy, pregnant with a single baby, and less than 41 weeks pregnant. The gray zone is that sometimes when the pregnancy goes past 41 weeks, some providers consider that to be a medically indicated induction rather than an elective induction. But in general, inductions are considered medically indicated when there are accepted medical problems or complications with the pregnancy that make it less safe to continue the pregnancy.
For many years, and I remember when I first entered kind of the birth world in 2012, a lot of people talked about the fact that, if you have an induction, it doubles your chance of cesarean. And then all of a sudden there were people saying that wasn't true. So can you talk a little bit about that controversy?
So for many years, the common belief was that elective induction doubled the cesarean rate, especially in first-time mothers. And then researchers nowadays consider those earlier studies to be flawed. In the earlier studies, what they would do is they would compare people assigned to elective induction to people who went into spontaneous labor. And nowadays, they don't compare those two groups anymore. They compare people assigned to elective induction to the people assigned to what's called expectant management, or in other words, waiting for labor. And in that group, the person could either go into spontaneous labor or they could require an induction for medical reasons. So that would be a medically indicated induction, or they could choose elective induction further on.
So that's a subtle difference, but an important one, because in the earlier studies, they compared elective induction to spontaneous labor, but you don't have the choice to go into spontaneous labor today. Your choice is to be induced today or to wait for labor to start. And sometimes during that waiting period, you might develop complications that require an induction, or you might change your mind and decide to have an induction, or you might go into spontaneous labor.
Right. So nowadays we compare a group assigned to elective induction to a group assigned to expectant management. And one example of this was the ARRIVE trial.
Yeah. So the ARRIVE trial was a study comparing elective induction at 39 weeks versus expectant management. And I just want to, we're not going to go into that trial in detail because we already covered it in detail in episode 10 of the Evidence Based Birth podcast. But they actually found a lower risk of cesarean in the elective induction group. And researchers think that had to do with the fact that the people in the expectant management group, more of them developed problems with blood pressure that required, medical inductions and had complications. So again, that just kind of goes to show you that it does make a difference when you compare elective induction to expectant management. Although one thing you have to keep in mind with the ARRIVE study is that they had a very low cesarean rate, in both groups compared to some settings. The cesarean rate was 19% in the elective induction group versus 22% in the expectant management group. So those research results cannot probably be generalized to settings with extremely high cesarean rates or high cesarean rates with inductions. We have for example, some professional members at Evidence Based Birth who talk to us about where they're practicing in their settings and how high the cesarean rates are with the elective inductions there. So I think you have to be careful how you generalize or apply that data from the ARRIVE study. And we talk more about that in episode 10 of the podcast. Which leads me to another point, and that is, some cautions about the evidence. When I say generalize, that means taking research from a research study. Can you apply that to your community, to where people are giving birth in your community? And so it's important to understand that there's some major drawbacks to some of the research that we're going to be talking about. Many of the studies are carried out in countries or time periods where there are low cesarean rates. So when that happens, when a study is carried out in a setting where culturally there's low C-section rates, that might not apply to a hospital with high cesarean rates. Um, if your hospital has high rates of quote failed inductions and strict time limits on the length of labor, then the evidence in these studies may not apply to you because induction might be more risky in your community hospital. Also, another disclaimer about the evidence in these trials, people are randomly assigned to induction or expectant management. And it's important to remember that the people assigned to expectant management do not always go into labor spontaneously. There's a mix of people in that group. Some of them do have a spontaneous labor, others have an elective induction later on, and others have a medical induction for complications. Also, you got to look at what they're doing for fetal testing in the studies. In some studies, there's lots of fetal testing going on in the expectant management group. However, there's also, we're going to talk about one of the studies where they were not doing any fetal monitoring during expectant management. So those results might not apply to your community if your community does the fetal monitoring and the study did not have fetal monitoring. Finally, another disclaimer about the research evidence is that the induction protocols vary from study to study and even within studies themselves. So, knowing what the protocol was for induction in that study can be very helpful to decide if this is going to apply to your unique situation, to your local community or not. So, with all of those disclaimers being said, there's been quite a lot of new research in the past year about induction at 41 weeks. So, Anna, can you talk about one of the most recent studies? Let's talk about the index trial from the Netherlands. There were two trials that came out in 2019, two large randomized control trials. And let's talk about the index one first.
Sure. So the index trial was from the Netherlands, and index stands for induction at 41 weeks, expectant management until 42 weeks. This was a large multi-center trial. It was conducted at 123 midwifery practices in 45 hospitals. And most of these pregnancies were managed by midwives.
So this was the midwifery-led model of care, which is very different than in the United States, which is typically an obstetrician-led care model.
Mm-hmm. But the researchers randomly assigned a total of 1,801 pregnant people to either induction at 41 weeks and 0 to 1 days, or to wait for labor until 42 weeks and 0 days, which is called expectant management. So the reason they were able to conduct this study in the Netherlands and got ethical approval for it is because it was standard practice for them to not induce labor before 42 weeks with an uncomplicated pregnancy.
So whereas in the US, it's rare to see someone go to 42 weeks. In the Netherlands, they typically won't induce you unless there's medical reasons until you get to 42 weeks.
Mm-hmm, exactly. So the mothers were enrolled in the study between 2012 and 2016. Everyone to be included had to be healthy, pregnant with single head down babies. The gestational ages were estimated with ultrasound before 16 weeks of pregnancy. They excluded people with a prior cesarean, with high blood pressure disorders, with expected problems with the baby's growth, abnormal fetal heart rate, or known fetal malformations or congenital anomalies. And in both groups, cervical ripening and induction methods depended on local protocol. It's like what Rebecca was talking about earlier. There wasn't a standard protocol to apply to both groups in this study when it came to cervical ripening and induction. It was based on local protocol. And this is an important weakness of the study because the providers might have managed labor inductions differently based on whether someone was being electively induced or was assigned to the expectant management group. It also limits the study's generalizability, which means our ability to apply the results of the study to the population at large, because providers don't have an induction protocol that they can replicate.
So we can learn from what happened in this study, but it's difficult for us to apply it to across the board because there's no specific induction protocol that could be followed.
Yeah. So what happened was in the elective induction group, 29% of the participants went into labor before their induction and 71% were induced. And then in the expectant management group, 74% of the participants went into labor spontaneously before their planned induction, and 26% were induced.
And before we talk about how long the pregnancies were, I think it's important for people to understand that when you have a randomized controlled trial like this, the researchers do something called intent to treat analysis. So it doesn't matter what type of birth they had, whether it was a spontaneous labor or medical induction, the data were analyzed depending on which group you were originally assigned to. So if you were assigned to an elective induction, but you happened to just quick go into labor on your own before the induction, you were still grouped with everyone in the elective induction group and vice versa. So it's just an important distinction for people to understand.
Mm-hmm. Yes. So what happened with these results is that the median pregnancy was only 2 days shorter in the elective induction group compared to the expectant management group. And this is interesting because they found, as we'll talk about, they found a difference between these two groups.
And this is important because a lot of people ask us like, well, I only want to wait 1 more day or 2 more days or 3 or 4 more days. But they're saying by decreasing the length of the pregnancy by 2 days, they found significant results. So what did they find in the index trial?
So for mothers, they found that there was no difference in the cesarean rates. This was taking place in a country with low cesarean rates. It was a midwifery model of care, and the rates were very low in both groups. They were 11% in both groups.
They only had an 11% cesarean rate then?
Mm-hmm. Yeah. And they also had an outcome called a composite outcome, which is a combined outcome for mothers. And there was no difference in that measure either. They were looking for things like excessive bleeding after birth, manual removal of the placenta, severe tears, intensive care admission, and maternal death. And they didn't find a difference in those things. There were no maternal deaths in either group. So as far as the bad outcomes for the mothers, they were about 11% to 14% in both groups, but not different.
And what about for the babies then?
And then for the babies in the elective induction group had a lower composite outcome rate. And in this composite outcome, what they were looking at was perinatal death, APGAR score less than 7 at 5 minutes, low pH, meconium aspiration syndrome, nerve injury, brain bleeds, or admission to a NICU. And here they found a lower composite adverse outcome rate with the babies in the elective induction group. And so that was 1.7% versus 3.1%.
And why do they think that outcome was better with the elective induction group?
They think that it was mostly due to the lower rate of APGAR scores less than 7 at 5 minutes. And that probably contributed the most to having a lower adverse outcome rate with the babies in the elective induction group. The authors note that there was no difference in rates of APGAR score less than 4 at 5 minutes, but they found that the combined outcome was still lower in the elective induction group if they used an APGAR score of less than 4 at 5 minutes and excluded fetal malformations. So basically, the babies in the elective induction group had better APGAR scores overall.
And what about stillbirths? Because that's like the main reason, right? They're doing these kinds of elective inductions is to lower the risk of stillbirth.
Yep, and they did not find a difference in stillbirth in this study. There was one stillbirth that occurred in the elective induction group. That was at 40 weeks and 6 days before the mother was induced. And then there were 2 stillbirths that occurred in the expectant management group while the mothers were waiting for labor. I looked for a few more details about those stillbirths because I was interested in that. And the 2 stillbirths that occurred in the expectant management group, one was a small for gestational age baby at 41 weeks and 3 days to a first-time mother. And the other one was to a mother with a prior birth, and that was at 41 weeks and 4 days. And the mother's placenta showed signs of infection of the membranes. And then the one stillbirth that occurred in the elective induction group at 41 weeks was to an experienced mother or someone who had already had given birth before. And that was at 40 weeks and 6 days, and there was no explanation for that one. But with 2 versus 1, they didn't find a significant difference in stillbirths between those groups.
And what was the protocol for fetal monitoring in that study?
There was no protocol for fetal monitoring. It depended on local guidelines, just like the induction and cervical ripening protocol. But the study authors say that fetal monitoring and assessment of amniotic fluid levels was typically done between 41 and 42 weeks.
So how would you sum up the results of this index study then?
So they found that elective induction at 41 weeks resulted in similar cesarean rates and less overall bad outcomes for babies compared to waiting for labor until 42 weeks. However, they say that the absolute risk of a bad outcome happening was low in both groups. It was 1.7% in the elective induction group versus 3.1% in the expected management group, or in the group that waited until 42 weeks.
All right. Well, the next study we wanted to talk about was the SWEEPIS trial from Sweden. So, also published in 2019, also coming out of Europe. And this it's SWEPIS, and it stands for the Swedish Post-Term Induction Study, or SWEPIS. And it got a lot of media attention with headlines like there was one that said, quote, post-term pregnancy research canceled after 6 babies died. And it is true that the study was ended early after deaths in the study. The researchers intended to enroll 10,000 mothers from multiple centers across Sweden, but they ended up stopping the study with about 1,380 people in each group after their Data Safety and Monitoring Board found a significant decrease in perinatal death between the groups. So, Data Safety and Monitoring Boards are basically a board that keeps track of what's going on in the study. They get interim reports, and if they see any concerning safety issues, they have the power to stop the study. So that's a standard part of a lot of randomized controlled trials, is to have one of these safety boards. Similar to the index trial in Sweden, just like in the Netherlands, labor is typically not induced before 42 weeks if you have an uncomplicated pregnancy. Also similar to the Netherlands, in Sweden, midwives manage most of the pregnancies and births. It's a midwifery-led model of care. And so the purpose of the SWEPA study was to compare elective induction at 41 weeks and 0 to 2 days versus expectant management and induction at 42 weeks and 0 to 1 day if the mother hadn't gone into labor by that point. So the study was carried out from the years 2015 to 2018. The researchers enrolled healthy mothers with single babies in head first position. They had accurate gestational ages. They excluded people with a prior cesarean, diabetes, and other complications such as high blood pressure, small for gestational age, or known fetal malformations. There is a pretty low stillbirth rate in Sweden, so they thought they would need about 10,000 people to see a difference between groups. But they ended up not needing nearly that many people to find a difference in stillbirth rates. One of the big strengths of the SWEPIS trial is that, in contrast to the index trial, in the SWEPIS trial, they defined an induction protocol, and they used that same protocol with everyone in the elective induction group and everyone in the expectant management group who had an induction. So the protocol was basically, if the mother's cervix was already ripe, they simply broke her water and gave her oxytocin as needed by IV. If the mother's cervix was not ripe or the baby's head was not engaged, they used mechanical methods or misoprostol or prostaglandins or oxytocin, but they did cervical ripening first. In the elective induction group, most of the people were induced. 86% had their labor induced. 14% went into labor spontaneously before the induction. In the expectant management group, 67% of them went into labor spontaneously, and 33% ended up with an induction. Similar to the index trial, really tiny difference in the length of pregnancy between groups. Pregnancy in the elective induction group was, in general, only 3 days shorter than pregnancy in the expectant management group, but yet they did go on to find significant differences. So, what the SWEPIS trial found was that for babies, this is why this study was stopped early. There were 5 stillbirths and 1 early newborn death in the expectant management group out of 1,379 participants, for a death rate of 4.4 deaths per 1,000 women. There were 0 deaths in the elective induction group out of 1,381 participants. All 5 stillbirths in the expectant management group happened between 41 weeks, 2 days, and 41 weeks, 6 days. 3 of the stillbirths had no known explanation. One was for a baby that was small for gestational age. The other was with a baby who had a heart defect. There was one newborn death that occurred 4 days after birth due to multiple organ failure in a baby that was large for gestational age. The authors mentioned that when complications are present at the end of pregnancy, such as problems with the placenta or the umbilical cord or fetal growth, these problems may become increasingly important as each day of pregnancy progresses, which they believe is why they found a higher death rate with expectant management past 41 weeks. Another key finding of the study was that all of these deaths occurred to first-time mothers, which suggests that the 41-week induction may be especially beneficial for babies of first-time mothers. They found that it only took 230 inductions at 41 weeks to prevent one death for a baby, and this was a much lower number than previously thought. If you remember, though, as Anna was saying, the index trial did not find a significant difference in death between the induction group and the expectant management group. We think the reason the SWEEPIS study found a difference was because it was a larger study. It was better able to detect differences in rare outcomes like death. Also, with the SWEEPIS study, there might not have been as good fetal monitoring. So it's possible that the better fetal monitoring of participants between 41 weeks and 42 weeks in the index trial might have been protective, leading to fewer perinatal deaths. We can't be certain because there were no fetal monitoring protocols in either trial. Another thing to note is that participants in the SWEEPIS expectant management group tend to give a birth a little later than participants in the index expectant management group, and that might help explain the higher perinatal death rate in the expectant management group in SWEEPIS. They did not find a difference in what they call the composite adverse perinatal outcome, which included death, low APGAR scores, low pH, brain bleeds, brain injury, seizures, and several other major complications. But there was that significant difference in perinatal death in either having a stillbirth or newborn death. Also, the elective induction babies were less likely to have an admission to intensive care, 4% versus 5.9%. They had fewer cases of jaundice, 1.2% versus 2.3%, and fewer of them were big babies, 4.9% versus 8.3%. For mothers, the outcomes were overall pretty good. There were no differences in cesarean rates, similar to the other trial. The cesarean rate in this study in both groups was about 10 to 11%. More mothers in the elective induction group had an inflammation of the inner lining of the uterus called endometritis, 1.3% versus 0.4%. And on the other hand, more mothers in the expectant management group developed high blood pressure, 3% versus 1.4%. And they also interviewed the women in both groups, and they found that the mothers in the expectant management group really struggled with negative thoughts. And they described feeling in limbo while they waited for their 42-week induction. So, Anna, can you talk a little bit about the fetal monitoring in this study and how it may have differed from the other study?
Sure. So fetal monitoring in this study was done per local guidelines. So there was no study protocol for fetal monitoring during the 41st week of pregnancy. However, the mothers recruited from one region of Sweden called the Stockholm region, which made up about half the people in the study. They had ultrasound measurements of their amniotic fluid volume and abdominal diameter at 41 weeks, whereas the people that came from the other areas of Sweden in the study did not receive these assessments regularly. And none of the 6 deaths that occurred in this study occurred in the Stockholm region of Sweden, where they received this type of fetal monitoring, which leaves us with the question of how important was this fetal monitoring? Could it have made the difference between the Stockholm region participants not experiencing fetal deaths, whereas participants from other regions did? So that's just an important thing to keep in mind with this study, is that the fetal monitoring may have made a difference as far as the perinatal outcomes. And it also means that the results of the SWEEPIS study might not apply equally to mothers who receive fetal monitoring at the end of pregnancy, specifically during that 41st week of pregnancy, which seems to be the really critical time period. And another thing, all of the perinatal deaths in this study occurred to first-time mothers, which tells us that the results might not apply equally to mothers who have already given birth before.
So in the SWEEPIS study, out of the mothers in the study who had already given birth before and were having a subsequent baby, none of them experienced a stillbirth or newborn death, correct?
Correct. Yeah.
Okay. So all of the perinatal deaths occurred to first-time mothers.
And the first-time mothers, by the way, they only made up about half of the participants in the sample. So it was about a 50-50 split.
So all of the fetal and newborn deaths from this study came from first-time mothers who lived in the areas of Sweden that did not do any prescribed fetal monitoring during that 41st week of pregnancy.
That's my understanding. Correct.
Okay, so those are the two big randomized trials that came out in 2019. Before they were published, there was a 2018 Cochrane meta-analysis. So, Anna, I was wondering if you could talk a little bit about that. This study did not include the SWEEPIS and the index trials, but we still wanted to talk about it in our article. So can you explain to our listeners a little bit about this Cochrane review?
Sure. So there was a 2018 Cochrane review and meta-analysis by Middleton. And unlike these randomized control trials that we were just talking about, they didn't focus specifically on the 41st week of pregnancy versus the 42nd week of pregnancy. It was much more broad than that. What they did was they looked at people who were electively induced at some point, compared them to people who waited for labor to start on its own until some point. So there was a much more broad range of gestational ages there. But they included 30 randomized control trials with over 12,000 mothers. And they compared a policy of induction at or beyond term versus expectant management. And all of the trials took place in Norway, China, Thailand, the US, Austria, Turkey, Canada, the UK, India, Tunisia, Finland, Spain, Sweden, and the Netherlands.
So it's quite a global sample.
Yes. But one study in this meta-analysis really dominated and accounted for about 75% of the data. And that was the Hannah post-term trial that I think Rebecca's going to be talking about soon. And because that one trial dominated this meta-analysis so much, most of the data was on giving birth at 41 weeks or later.
And they did not include the ARRIVE trial in this meta-analysis.
They didn't ARRIVE, Index, or SWEPIS. So in its next update, it's going to be updated with those 3 randomized control trials. But they did include 30 other randomized control trials. And what they found was that a policy of induction at term or beyond term was linked to 67% fewer perinatal deaths compared to expectant management. So that was 2 deaths with induction at or beyond term versus 16 deaths in the people assigned to expectant management. And the Hannah post-term trial excluded deaths due to fetal malformations, but some of the smaller trials that were included in the Cochrane meta-analysis did not. So if we exclude the 3 deaths from severe fetal malformations, then the final count is 1 death in the induction group and 14 in the expectant management group. So it doesn't change the results too much overall to exclude fetal malformations. And overall, they found that the number needed to treat was 426 people with induction at or beyond term to prevent 1 perinatal death. And specifically, there were fewer stillbirths with a policy of induction at or beyond term.
Which was a different number needed to treat than the SWEEPIS trial, which found only took 230 inductions at 41 weeks to prevent 1 perinatal death.
Yeah, I think part of the reason the SWEEPIS trial was so groundbreaking and got so much media attention is because it did find a lower number needed to treat than had been found previously. So the absolute risk of perinatal death was 3.2 per 1,000 births with the policy of expectant management versus 0.4 deaths per 1,000 births with the policy of induction. And they found that a policy of induction was linked to fewer cesareans compared to expectant management, 16.3% versus 18.4%. Fewer babies assigned to induction had APGAR scores less than 7 at 5 minutes compared to those assigned to expectant management. And they didn't find any differences between the groups in the rate of forceps or vacuum assistance at birth, perinatal trauma, excessive bleeding after birth, total length of hospital stay for the mother, newborn intensive care admissions, or newborn trauma. So the authors concluded that individualized counseling might help pregnant people choose between elective induction at or beyond term or continuing to wait for labor. And they stressed that providers should honor the values and preferences of the mothers. But we need more research to know who would or would not benefit from elective induction. And the optimal time for induction is still not clear from the research, which is what they said in 2018. So I think Rebecca's going to talk about the famous Hannah post-term study that accounted for 75% of the data in that meta-analysis.
Yeah, so we're kind of working backwards through time. We started with the 2019 randomized trials, then the 2018 meta analysis, where they said the optimal time for induction is not clear, but they stated that before the two new randomized trials came out. And then, even before then, going back in time, is the 1992 Hannah post term study, which is one of the most important studies on inducing for going past your due date. And it was the largest randomized trial ever done on this topic, larger even than Index or Sweetbus. And it controls most of the findings in that Cochrane meta analysis that Anna just described. So let's look at what happened in this study because it plays so much of a role in the meta analysis. It was carried out between the years 1985 and 1990 when a group of researchers enrolled 3,407 low risk pregnant people from 6 different hospitals in Canada into the study. Women could be included if they were pregnant with a live single fetus, and they were excluded if they were already dilating, if they had a prior cesarean, pre-labor rupture membranes, or a medical reason for induction. This study had a much different expectant management protocol than Index or Sweetbus because unlike those studies where like the longest you would go was 42 weeks and 0 to 1 days, and the Hannah post-term study, the people assigned to expectant management were monitored for as long as 44 weeks pregnancy before they were induced. So up to a month past your due date, which is almost unheard of today. And at around 41 weeks, people who agreed to be in the study were either randomly assigned to have an induction of labor or fetal monitoring and expectant management. In the induction group, labor was induced within 4 days of entering the study, usually about 41 weeks and 4 days. If the cervix was not ripe and if the fetal heart rate was normal, they were given a prostaglandin E2 gel to ripen the cervix, and they used a maximum of 3 doses of gel every 6 hours. If this did not induce labor or if they did not need the gel, people were given IV oxytocin, had their waters broken, or both. And they could not receive oxytocin until at least 12 hours after the last prostaglandin dose. So, one strength of this study is that it had a defined induction protocol that providers could replicate. But the big weakness of this study is that the expectant management group did not have that same induction protocol. In the monitored or expectant management group, people were taught how to do kick counts every day, and they had a non-stress test 3 times per week. They also had their amniotic fluid levels checked by ultrasound 2 to 3 times per week. And labor was induced if there were concerning results on the non-stress test, or if there was low amniotic fluid, or if the mother developed complications, or if the person did not go into labor on their own by 44 weeks. And if doctors decided the baby needed to be born, mothers in the expectant management group did not receive any cervical ripening. Instead, they either had their water broken and or IV oxytocin, or they just went straight to a cesarean without labor. So, Anna, do you want to talk a little bit about what the researchers found in this study?
So what the researchers found in the Hannah post-term study is that in the induction group, 66% of the people were induced and 34% went into labor on their own before induction. And in the monitoring group or the expectant management group, 33% were induced and 67% went into labor on their own. So there were 2 stillbirths in the group assigned to wait for labor and 0 in the group assigned to induction. And this difference was not considered to be statistically significant, which means we don't know if it happened by chance or if it was a true difference between the groups. The much more interesting outcome to look at with the Hannah post-term trial are the findings on cesarean rates because they differ depending on what numbers you look at. You can either look at the outcomes for the 2 original groups, which were the people randomly assigned to induction and then those assigned to fetal monitoring, or you can look at the breakdown of what actually happened to the people in the 2 groups. In other words, what happened to the people who were actually induced or who actually went into spontaneous labor. So what happened in the original randomly assigned groups? If you look at the 2 original groups, the overall cesarean rate was lower in the induction group. It was 21.2% versus 24.5%. That was even after taking into account factors like the mother's age, whether or not it was her first baby, and cervical dilation at the time of study entry. Or you could look at what happened with the people who were actually induced or who actually went into labor on their own. And if you look at that, you see 2 very interesting things. You see that people who went into spontaneous labor regardless of which group they were assigned to, they had a cesarean rate of only 25.7%. But if people in the monitoring group had an induction, their cesarean rate was much higher than all of the other groups. It was 42%. The same was true for both first-time mothers and for mothers who had given birth before. So what does this mean? It means that only the people who were expectantly managed but then had an induction had a really high cesarean rate. The people who were expectantly managed and then went into labor spontaneously did not have a higher cesarean rate. And one possible reason for this, for the high cesarean rate seen in the people who were assigned to expectant management but then ended up getting an induction, is that the people in this group might have been higher risk for cesarean to begin with, since a medical complication could have led to their induction. The people that were assigned to expectant management and never developed a complication requiring an induction, those were the lower risk people, which means they were the ones less likely to end up giving birth by cesarean. And then another important factor that I know Rebecca has discussed previously is that doctors might have been quicker to call for a cesarean when assisting the labors of people with medical inductions if their pregnancies were beyond 42 weeks. They may have been less patient waiting for labor.
Or more easily worried about the course of the labor, big
More
baby,
worried.
etc.
Mm-hmm.
Yeah. So basically, it seems like from the Hannah post-term trial, one of the benefits of considering expectant management is that if you do have spontaneous labor, your chance of cesarean is pretty low. But the risk is that you'll develop medical complications or need an induction, in which case an induction at 42 weeks is going to be riskier than an induction at 41 weeks.
Mm-hmm.
So why do you think we have all this research from all over the world, from the Hannah post-term to the 2018 meta-analysis to 2 trials out in 2019? Do you still feel like routine induction at 41 weeks is still going to be controversial or not?
I think it's definitely still controversial, and I think everybody's still processing the results from the index trial and the SWEPIS trial. Rebecca and I reached out to Dr. Wienerholm, who conducted the SWEPIS trial in Sweden, and she said she's right now working on secondary analysis of the data, and they're talking about the economic implications of the findings in Sweden and what it means for Swedish national policy. So I think it's still controversial. People are still talking about what to make of these findings. And there was another systematic review from 2019 by Rydal, and this one came out too early to include the SWEPIS and the index trials. But it's still interesting to look at because unlike the Middleton-Cochrane review, these authors were specifically interested in induction during the 41st week of pregnancy versus during the 42nd week of pregnancy. So in their analysis, they restricted the studies only to people having a routine induction at 41 weeks and 0 to 6 days versus routine induction at 42 weeks and 0 to 6 days. If you remember, the Cochrane review was much broader than that. So they also only looked at studies published within the last 20 years. They only looked at studies with low-risk participants. And they ended up with 3 observational studies, 2 randomized control trials, and 2 studies that they called quasi-experimental studies, which they grouped with the randomized control trials, even though these studies weren't truly randomized. And what they found was 1 perinatal death in the 41-week induction group and 6 deaths in the 42-week induction group. That was a rate of 0.4 versus 2.4 per 1,000. And they found that this finding was not statistically significant. In other words, we don't have strong enough evidence that this couldn't have happened by chance. And these same studies, those 2 randomized control trials and the 2 quasi-experimental studies, they showed no difference in cesarean rates between groups also. But the authors did report that 1 observational study found an increase in the cesarean rate with the 41-week induction group. So basically they're saying if you look much more narrowly at the evidence of induction during the 41st week versus the 42nd week, then there might not be a significant difference in the death rate.
But that Rydal study from 2019 is already outdated because that was before the 2 big randomized trials came out.
Yes, we need to see a systematic review and meta-analysis that includes those 2 randomized control trials and see if that changes. These authors also expressed concerns about the cesarean rate possibly rising with 41-week induction because both the SWEPIS study and the index trial, they both took place in countries with very low cesarean rates. So we just don't really know at this point whether there would be a difference in cesarean rates if they took place in countries with higher rates of cesarean, such as the US. So I think it is still controversial. There's also some countries are changing their policies about induction, and then they're going back and looking at whether that policy change led to any difference in outcomes. And one such country is Denmark. They just published a study where they compared their birth outcomes from 2000 to 2010 versus 2012 to 2016. And in that time period, there was a change in policy from recommending induction at 42 weeks and 0 days to 41 weeks and 3 to 5 days. They included over 150,000 births in the data set. And when they looked back, they didn't see any difference in stillbirths or perinatal deaths or low APGAR scores when they compared the period before versus after the policy change. The perinatal death rate was already declining before the policy change in 2011, and it just continued going down without any additional impact from the 2011 policy change. There was also no impact on the rate of cesareans with the policy to switch from 42 weeks to 41 weeks. So that's just an example of how this is still controversial. Countries are implementing new policies, and Sweden and the Netherlands may implement new policies based on the index and the SWEPIS studies, and then they'll probably study the way that Denmark did to see if that policy change had any real impact on the population.
I think it's important to mention, though, that the Denmark national policy, they switched from 42 weeks and 0 days to 41 weeks and 3 to 5 days, and that might not have been early enough to make an impact on the stillbirth rate, because the studies that we were looking at from 2019, SWEPIS and Index, were looking at inductions happening at 41 weeks and 0 to 1 or 2 days, and that it was that couple of days difference that made the difference between low stillbirth rate and a higher stillbirth rate.
Right, exactly. I think in the future, researchers shouldn't group 41 weeks and 0 to 6 days together in one grouping, because there seems to be differences between the earlier part of the 41st week and the later part of the 41st week, because like you said, SWEPIS and Index are finding even just 2 or 3 days make a difference in outcomes during that week.
So let's talk, just like sum up the pros and cons of induction at 41 weeks versus continuing to wait for labor, since that's what we have the bulk of the evidence on now. I would say that the research shows that the pros of inducing labor at 41 weeks include a lower risk of stillbirth, especially among those with risk factors for stillbirth, such as being pregnant with your first baby. And in our article, we do, in a table of pros and cons, list the absolute risk of stillbirth. It's 4 out of 10,000 pregnancies at 39 weeks, 7 out of 10,000 pregnancies at 40 weeks, 17 out of 10,000 pregnancies at 41 weeks, and 32 stillbirths out of 10,000 pregnancies at 42 weeks. Research also shows a lower risk of the baby receiving intensive care with an elective induction at 41 weeks, lower risk of the baby having jaundice, lower risk of the baby being large for gestational age, lower risk of needing a cesarean, although that finding may depend on your practice setting, the lower risk of mother developing a high blood pressure disorder. And for some people, they find an elective induction at 41 weeks convenient, and it helps them end an uncomfortable pregnancy. Also, in our article, we reference one study that found, one observational study did find some cognitive benefits for babies that say that the benefits for the mom remaining pregnant appear to increase until about 40 to 41 weeks, after which there's no cognitive benefits to the baby's brain development for continuing to remain pregnant. So Anna, can you share the cons of elective induction at 41 weeks?
Yeah, so one of the cons of being induced at 41 weeks instead of continuing to wait and see if you go into labor is the potential for medicalization of birth and the cascade of interventions. One example of this is continuous fetal monitoring may occur if you have the induction, whereas you might not get continuous fetal monitoring if you go into labor on your own spontaneously during that 41st week. Another con would be a potential for failed induction leading to a cesarean, and that also depends a lot on your practice setting. Another con is the potential for uterine tachysystole, which is defined as more than 5 contractions in 10 minutes, averaged over a 30-minute window. And there's a potential increase in the risk of uterine rupture with medical induction. That is especially important among people with a previous cesarean having a VBAC. Another con is missing the hormonal benefits of spontaneous labor. Another con is increased risk of mother getting inflammation of the inner lining of the uterus, endometritis. One study found that as a possible risk of induction 41 weeks. And then lastly, medically induced contractions might increase pain and make epidural use more likely.
We also have a section in the article where we talk about, are there any benefits to going past your due date? That table we just took you through was comparing the benefits and risks of elective induction. In terms of benefits of going past your due date, one of the major benefits of awaiting for spontaneous labor are the hormonal benefits, which Anna briefly mentioned. And in our article, we link to the book Hormonal Physiology of Childbearing by Dr. Sarah Buckley, which talks about the physiologic understandings and the physiology of spontaneous labor. And so that is something to keep in mind. And that's one reason why some people prefer to wait for spontaneous labor. So, Anna, if someone wants to wait for labor to begin on its own and they're talking with their care provider about expectant management, what's kind of the bottom line about that?
I think the bottom line about that is it all needs to be very individualized. When someone goes past their estimated due date, they could talk to their care provider about the benefits and the risks of elective induction versus continuing to wait for labor and how those benefits and risks apply to them personally. Most research articles and guidelines say that because there are benefits and risks to both options, the pregnant person's values, goals, and preferences should play a part in the decision-making process. It's important for expectant families to be aware of the growing research evidence showing that there could be worse health outcomes for those who wait for labor after 41 weeks of pregnancy instead of being induced at 41 weeks, especially among first-time mothers and those with additional risk factors for stillbirth. But ultimately, after receiving accurate evidence-based information and having conversations with your care provider, pregnant people have the right to decide whether they prefer to induce labor or wait for spontaneous labor with appropriate fetal monitoring.
So I want to also let people know about a couple more resources that are in this article at evidencebasedbirth.com/inducing due dates. We have a section all about how people and their care providers can talk about the risk of stillbirth with some sample scripts that healthcare providers can use when they're talking about risks of stillbirth. We also have links to different guidelines from different organizations about induction at 41 weeks. And then we also have our section called the bottom line. So what would you say are some of the bottom lines, Anna, about elective induction at 41 weeks and 0 days?
Okay, I think the bottom line is that elective induction at 41 weeks and 0 days could help to reduce stillbirths and poor health outcomes for babies without increasing harm like the risk of cesarean for mothers. And that really, we're getting that from those two large randomized control trials published in 2019 that both found benefits to elective induction at 41 weeks instead of continuing to wait for labor until 42 weeks. One of those studies, as we mentioned, found less perinatal death with 41-week induction, and the other found fewer poor health outcomes for babies like intensive care unit admission and low APGAR scores with 41-week induction. Neither of those trials found an increase in the risk of cesarean during birth with 41-week induction compared to continuing to wait for labor until 42 weeks. However, both of those trials took place in countries that followed the midwifery model of care, and the overall cesarean rates were very low. So I think it waits to be seen how that will translate into countries like the US.
So I hope you all found this podcast helpful in looking at the recent research on induction at 41 weeks versus expectant management. Make sure you check out the blog article that goes along with this podcast episode for all of the resources, links, research references. And we also have a free one-page handout you can download that summarizes the results of this research. So just go to evidencebasedbirth.com/inducing due dates to download that new article. Thank you so much, Anna, for joining us to help our listeners understand the evidence.
Happy to do it, Rebecca. Thank you.